Starvation hepatitis can lead to fulminant liver failure during refeeding syndrome if not monitored closely. Hi, my name is Dr. Oscar Hernandez alongside my colleagues Marwa, Hussain, MS4, Doctors Gaisinskaya, Shah, and Zahra, and today we would like to present a case of starvation hepatitis and refeeding syndrome in the curious case of excessive meditation. For some background, the DSM-5 definition of anorexia nervosa includes persistent behavior that interferes with weight gain. Religious observances, such as meditation, may be construed to unintended lengths and induce long-term starvation states. Hepatitis secondary to starvation is theorized to derive from hepatocellular autophagy and eventual apoptosis, as intracellular proteins are slowly but surely derived. Refeeding syndrome complicates starvation hepatitis injury through sudden cellular utilization of already expended ions and metabolites. Fulminant liver failure has been seen in patients presenting with starvation hepatitis complicated by refeeding syndrome. For our case, we had a 25-year-old male with no prior medical history who presented in emergency services custody following a wellness call by his mother. He had been on a video chat call with his mother who had been overseas and who had not seen him for 8 months. She noticed that he was cachectic and therefore called a wellness call. The patient had previously been a bodybuilder up until about 8 months ago when he became a religious convert. He used meditation daily and practiced it daily in an effort to achieve a sense of enlightenment and began to meditate through his meals. The patient stated that by meditating through his hunger, he felt like he was getting closer to his sense of enlightenment and therefore would do so every day. He rarely ate a meal and would have a meal or two every 2 to 3 weeks, consisting mostly of bread or water, and therefore experienced a 75-pound weight loss within 6 months. At presentation, the patient denied any concerns over his cachectic appearance, but he did note right-sided jaw pain following a syncopal episode that occurred 3 days ago. On physical examination, the patient had a BMI of 14.1 and was bradycardic with a beats per minute of 51. Initial lab values indicated a hepatocellular injury on the initial lab work done. Graph 1 illustrates a trend of his ALT and AST according to admission day. On admission day 1, his AST was approximately 87, whereas his ALT was approximately 200. The red lines on either graph 1 and graph 2 represent the days in which refeeding was initiated, and that was on admission day 2. Back to our patient, a CT of the head found a displaced right jaw fracture. Therefore, an orthopedic surgical consultation was conducted, and he underwent a surgical repair of his jaw, which required wiring of his jaw. He was initiated on a restricted liquid diet in consultation with a nutritionist who estimated that his daily caloric intake goal was approximately 1,000 calories per day. Following this, on admission day 2, he had a severe elevation in his ALT values. As demonstrated on graph 1, you can see that the ALT here goes from approximately low 200s to up to 300 in an acute change. This acute change is reflected by an acute elevation as well in his BMI, as represented in graph 2. A right upper quadrant of ultrasound was conducted, which showed some fatty liver infiltration without other pathology. Therefore, his caloric goals were reevaluated in close consultation with a nutritionist, and after further discussion with the patient, he admitted to overeating quickly to facilitate a quicker discharge, as he believed that increasing his BMI in a quicker state would get him to a point where he could be discharged more quickly. Most concerning was that on admission day 4, the patient developed acute onset chest pain. An EKG was conducted which showed diffuse T-wave flattening as well as hypokalemia on serology. This resolved with the utilization of calcium gluconate and potassium repletion. By admission day 6, his electrolyte abnormalities had stabilized, and the patient was stable enough to be discharged home with family care after a Baker Act was lifted. Our patient suffered from acute liver injury in the setting of refeeding syndrome with underlying starvation hepatitis. It was prompt caloric reevaluation and close follow-up with a nutritionist, which helped reduce the severity of his liver injury and potentially prevented him from progressing into fulminant liver failure. Aggressive electrolyte repletion is necessary in these patients who are undergoing refeeding syndrome. Unfortunately, refeeding syndrome is an often underdiagnosed condition, yet it has large implications on mortality for patients in starvation states. If you would like to know more, you can use your mobile device camera and scan this QR code for a full evaluation of this paper. Thank you.